The tibialis posterior muscle. The tibialis posterior muscle lies deep to the gastrocnemius and soleus muscles of the calf. This muscle primarily functions to guide the transmission of body weight through the proper bones of the foot. It is not typically active during the push-off phase of normal gait, but becomes active when the foot strikes the ground and becomes weight-bearing. Contraction of the tibialis posterior produces inversion of the foot, and it is also a weak plantar flexor. The tibialis anterior and the toe flexors assist the tibialis posterior during inversion, and the gastrocnemius and soleus are the major synergistic muscles during plantar flexion. The peronei oppose the tibialis posterior during inversion, and the tibialis anterior opposes the tib posterior during plantar flexion. Some activating or perpetuating factors for the trigger point in the tibialis posterior muscle include running or walking on a sloping or uneven surface, eversion of the foot while walking or running due to poor shoes, a tendency to pronate the foot while they're walking, and hyperuricemia or gout conditions. The trigger points in the peroneal muscles are functionally associated with tibialis posterior trigger points. With the client in the prone position, locate the crease of the knee, and then about a third of the way down between the crease of the knee and the Achilles tendon, you'll find the tibialis posterior trigger point. Using a thumb over thumb contact, you're going to apply pressure straight down. Now remember, you're going to have to push the gastrocnemius out of the way a little bit, because the tibialis posterior is deep to both the gastroc and the soleus muscles. Use your elbow, push the gastroc out of the way, and then apply pressure straight down.
We already know the tibialis posterior is a super tricky muscle to get to. It's on the back of the tibia, hence the creative name. So it's really hard to wrap your fingers around that bone and get into that muscle. And the first thing I like to do is actually try to push the soleus away, which is the muscle that kind of lies more posterior to that. So in this clip, I'm starting on the medial border of the tibia, and I'm pushing down towards the table, kind of starting to remove the fibers of the soleus away from the tibialis posterior. Deeper work into the tibialis posterior. So I want to repeat this, moving up the entirety of the muscle, making sure that I'm kind of hitting every aspect of it, really softening it up and working through that tension, releasing those muscles even farther away from the tibialis posterior. I'm about to get into the grunt work of this muscle, so I want to slide my thumb up the medial border of the tibia one more time just to see where my client's adhesions are particular. And this is one of them. The tibialis posterior attachment against the tibia is extremely painful to work at. So in this clip, I'm starting to actually wrap my fingers around the tibia, underneath the tibia, sinking in and then pulling up towards the front of the bone actually, so kind of my pressure is coming up away from the table, and I'm applying friction. So using both hands here to support my fingers and pulling up underneath the tibia and applying friction up and down along the fibers of the muscle. It's really important to repeat that last technique as much as needed and make sure that you're communicating with your client about how they feel, and that there's a difference between good pain and bad pain. It's a little kind of a fine line with this work, but you want to break through those adhesions and make sure that muscle is nice and free from the tibia. Once you've done that, make sure you make nice. It is unbelievably important. Nobody wants to feel like your fingers are still sticking into their legs when they walk away from your table. So give them some nice work, give them a nice massage, and send them away happy. There truly is an unlimited number of possibilities that we can use to work with the soft tissue of the body. I would love to hear what you guys do.
The tibialis anterior is the primary dorsiflexor of the ankle, and the innervation comes from the deep peroneal nerve. Injury of the L5 nerve root can cause weakness of the tibialis anterior muscle. The L5 nerve root also causes dorsiflexion of the toes through innervating the extensor hallucis longus, the extensor digitorum longus, and this innervation comes from the deep peroneal nerve. So when the L5 nerve root is affected, the extensor hallucis longus could become weak. The tibialis posterior is an important muscle that runs behind the medial malleolus. Its innervation comes from the posterior tibial nerve to assist in plantar flexion of the ankle and to maintain the medial longitudinal arch. The L5 nerve root also innervates the muscles that cause hip extension, and the muscles are the hamstrings, which is innervated by the tibial nerve, and the gluteus maximus, which is innervated by the inferior gluteal nerve. The hamstring muscles are also a major flexor of the knee. The L5 also innervate the hip abductors, the gluteus medius and minimus, and the innervation comes from the superior gluteal nerve. Injury of L5 nerve root can cause weakness of the hip abductors, and this can lead to a Trendelenburg gait. L5 nerve root is part of the lumbosacral plexus as you see here. It is an important component of the sciatic nerve. As you can see here, the L5 nerve root is really an important nerve root and it supplies a lot of muscles. This is a summary of these muscles: the tibialis anterior, the primary dorsiflexor of the ankle, innervation from the deep peroneal nerve. Injury of the L5 nerve root will cause foot drop. The extensor hallucis longus and the extensor digitorum longus, big toe and other toes extension. Innervation from the deep peroneal nerve. Injury of L5 nerve root will cause weakness of extension of the toes, including the big toe. Tibialis posterior inverts the foot and assists in plantar flexion of the ankle and maintain the medial longitudinal arch. Innervation comes from the posterior tibial nerve. The hamstrings can cause hip extension and also are a major flexor of the knee. Innervation comes from the tibial nerve. The gluteus medius and minimus causes hip abduction. Innervation comes from the superior gluteal nerve. Injury to L5 nerve root can cause weakness of hip abduction and Trendelenburg gait. Gluteus maximus causes hip extension. The nerve supply to the gluteus maximus is given by the inferior gluteal nerve, L5, S1, and S2, mainly S1 nerve root. The L5 nerve root gives sensory innervation to the top of the foot.